This conference will now be recorded.
Okay, hi everyone. My name is Ashraf Gorgey. I'm the chief and chair of the FES Task Force Committee hosted by the American Congress of Rehab Medicine. I've been running the task force for the last 3 years, and we have been delivering excellent, outstanding webinars to the field of rehab medicine with the hope to enrich clinicians and researchers with the cutting edge outcomes or research topics related to the field. Our task force is geared towards tying both clinicians, physical therapists, rehab scientists, exercise physiologists, occupational therapists, and all of the above together, as well as tying them to clinicians who have been seeking knowledge in different topics. This is just a quick reminder, excuse me, that our annual conference will be held in Atlanta this year in October 21 to October 24, October 21st to 24th. And we are hopeful that if you can plan to attend the annual conference to be part of our FES and technology task force. Some housekeeping remarks before we start. I would like to ask everyone to mute his phone or to mute his computer because the presentation is being recorded. So hopefully we don't have any background noise. Also, it's been a pleasure and honor to introduce Dr. Enrico Rejc. Dr. Enrico Rejc received his PhD in exercise physiology from University of Udine, Italy, where he also worked as a research assistant professor, taking a position at University of Louisville, Kentucky. He was also involved in research activities at the Department of Integrative Biology and Physiology at University of California, at the Institute of Biophysical and Clinical Research into Human Movement at Manchester Metropolitan University at United Kingdom. Has also studied the human neuromuscular system and its adaptation to spinal cord injury, prolonged disuse, aging, and exercise for over 12 years. Since 2010, he has been involved in research projects that investigate the effects of lumbosacral spinal cord epidural stimulation on the recovery of motor function in individuals with chronic complete spinal cord injury. His research primarily focused on investigating the effects of epidural stimulation parameters, peripheral sensory information, and the training on the modulation of the spinal neural networks during standing and volitional movement. Dr. Rejc has been involved in numerous national and international presentations. And without further ado, Dr. Rejc Enrico, please go ahead. And we're looking forward to your presentation.
Hey, let me share the screen. Okay, so thank you, Ashraf, for your introduction, as well as invitation to this webinar. I was, happy earlier, and I'm even happier now, because so this, March and April were supposed to be very productive months for me in terms of invited talks and chairing conferences. But then, as we all know, everything got canceled. So at least, this really makes feel things a little bit more normal. I just want to wish all the audience and their families to be safe and stay well for the next upcoming weeks, which will be, unfortunately, challenging. Now, moving to the actual today's presentation, what I would like, I have divided it into four main parts. So the first one is kind of devoted to a short background and then a summary of characteristics of motor function recovery we have observed over the last decade by applying epidural stimulation in individuals with motor complete spinal cord injury. And then the last three parts are more related to discussing into details of three among the most important factors to actually achieve motor recovery with epidural stimulation, that are stimulation parameters that we apply, the characteristics of activity-based training, and also some insight on some new work we have done related to the individual specific characteristics after spinal cord injury. And so I just want to start by, again, a brief introduction. So we know that after chronic complete spinal cord injury, there is inability to stand and walk, primarily because of the loss of tonic supraspinal drive to the spinal circuitry controlling posture and locomotion. But it's important to keep in mind that, you know, very often this circuitry is below the level of lesion, and that it remains intact after injury, as well as capable of interacting with the peripheral sensory information. And this is important because spinal stimulation for motor function recovery aims at capitalizing on the residual sensory motor potential that the spinal cord still persists, that persists in the spinal cord after SCI. And there are three main characteristics that I want to point out. So the first one is the automaticity of the spinal cord. So we know that even after, you know, even in an ex vivo preparation, spinal cord is capable of generating meaningful activation patterns if properly stimulated. And then, you know, when we transition into a more functional context, for example, you know, a motor complete individual, you know, when a motor complete individual receive passive, you know, performs passive stepping because of the assistance delivered by therapists. And if we put EMG electrodes here, we can actually record, you know, locomotor-like EMG activity in response to this passive stepping. And this is another example of automaticity of, again, of the spinal cord modulated by peripheral sensory information. Then the second important characteristics is the plasticity of the spinal cord. So from many animal studies, we know that even after a complete transaction, the spinal cord can learn to perform a motor task. And this is just an example from, you know, Egerton groups showing that cats that were trained to step achieved better stepping ability as well as better stepping activation pattern as compared to those that were left to spontaneous recovery. And the third important component is that you know, the vast majority of clinically motor complete injuries are not anatomically complete. And even though that spare tissue doesn't lead into detectable or functional outcomes under normal circumstances, it can really play a crucial role when spinal stimulation is provided. So now moving on to the device we use for spinal stimulation, we use the Medtronic stimulation unit. We started with the Restore Advanced and then moved to the Intellis. And so this stimulation unit is connected to a 16 electrode array that is implanted generally at T11, L1 vertebral level. And today I'm not really going to talk more about the surgical procedures. For whoever is interested about that, we have a couple of dedicated papers out there. One has been published last year, and another one is under review in Journal of Neurotrauma. And so this really, talk in more details about surgical procedures as well as infection preventions. So now, in terms of mechanisms involved in spinal stimulation, to date, the main view is that spinal stimulation primarily recruits large somatosensory fibers at their entry to the spinal cord, thus altering the excitability of the spinal circuitry that are involved in motor pattern generation. And so when we move into a more kind of functional flow chart, we can see as, for example, we aim at applying epidural stimulation to modulate and often increase the excitability of the spinal circuitry controlling posture and locomotion, which has an intrinsic capability to generate meaningful activation patterns, which can then be modulated both by peripheral sensory information as well as residual supraspinal input. And this is an example of this enabling stimulation strategy, and I would say it's really an important slide, because you see here, we have this set of stimulation parameters that are applied both during sitting and then during the transition and during standing. But you see that again, these stimulation parameters do not directly induce any movement, as well as
if you can possible to mute the background, please. Please mute your background.
Yeah,
sorry about this.
And so I was saying that again, that this stimulation doesn't really induce neither muscle activation nor movement during a quiet sitting condition, as well as, but however, without any change in stimulation parameters, the sensory information related to the sit-to-stand transition, that really leads to the generation of an appropriate activation pattern. And, this is another example where we have a research participant, standing on a body weight support on a treadmill. And when epidural stimulation applied to facilitate stepping is applied, then we see that we have only a couple of muscles really active, and then most of them are either silent or with just a negligible activation. But then again, when the same exact stimulation parameters are applied and the stepping related sensory information merge into the spinal circuitry, at that point, we really get this nice and robust locomotor-like activity. So this is really two examples that show how important is the combination of epidural stimulation and task-specific sensory information. So now again, I'm kind of going through a couple of examples of motor tasks that we were able to recover. And I will start with showing, what do we usually get when a chronic motor complete individual perform an assisted sit-to-stand transition. And so we usually detect some EMG activity during the dynamic phase of the sit-to-stand transition. But then again, this individual really needs full assistance to maintain, knees extension as well as hip extension. And then in this case, he also basically self-assist balance. And so we have basically little or no EMG activity during quiet standing. But then, this is what we got with the same individual after months of training with epidural stimulation. So basically, he was able to keep an independent standing with self-assistance for balance just provided by one arm, and while also, being able to perform some side motor tasks with the opposite arm. So this is an example of motor recovery for standing. We also know that, again, motor complete paralysis, there is obviously an ability to move voluntarily the lower limb, and this was an example of trying to achieve ankle dorsiflexion, and obviously, no EMG activity and no movement. However, when we applied individual-specific stimulation parameters at a sub-threshold intensity, sub-motor threshold intensity, then we were able, participants were able to actually generate meaningful activation patterns and activate the primary agonist muscles, as well as generate movements, depending on the motor task that was requested. And in this case, we started with whole lower limb flexion, and then also ankle dorsiflexion, and just wiggling the toe. So we know that appropriate spinal stimulation can also enable, again, volitional lower limb movement. And then, now, the next step was to try to integrate the volitional contribution during weight-bearing motor tasks. And this now, seemed really straightforward, but at the beginning it wasn't like that. And in the next slide, we'll kind of show an example as to why it wasn't as straightforward. But anyhow, so this slide here shows us, this individual can maintain independently, standing, and can also volitionally basically inhibit activation of most of the lower limb muscles, then ending up into a squatted position, kind of seated into these two elastic beds, and then again volitionally recover extension and go back into standing. So this is an example of volitional contribution during weight-bearing tasks. And this is another example, again, that at the beginning was a little discouraging, because when we asked, this research participant to try to contribute to stepping, but in an acute setting or without any specific training for that. So this is what happened. So we ended up basically with impairing the stepping pattern, and also basically, increasing I don't know if anybody can mute their own microphone, because otherwise we'll get the echoes.
Please mute your background or your computer. Please mute your background or your computer.
Thank you. And so, yeah, and so basically, without specific training, you can actually get an overall impairment, both in activation pattern and in stepping kinematics, if you ask an individual to volitionally contribute to stepping, for example. However, when these three main components were, embedded into months of training, so appropriate stimulation, training, and volitional contribution, then we really ended up with the ability of most of the research participants to start achieving either, independent step cycles. So, and they start with just part of the step cycle, either flexion or extension. And most of them transition into, the ability to actually complete the whole step cycles independently. And then, with further training, as you may have heard, so 2 Asia B individuals were able to recover independent walking over ground with self-assistance for balance. So this was kind of a quick presentation and highlights of the motor tasks that we were able to recover and achieve in some of these chronic motor complete individuals. And now what I want to do is kind of talk in a little more details about 3 of the main key factors for achieving these motor outcomes. And the first one is basically the stimulation parameters we apply. And I will start with the electrode configuration. And this is, a very tricky parameter to set, because with a 16 electrode array, there are over 4 million different potential combinations of electrodes. So how do we select them? So far, we don't really have, a specific algorithm that set the parameters for us. So we really need to go through some guidelines as well as previous literature. And so one approach to keep in mind is the topographical recruitment. So we know that if we stimulate more rostrally, there is a greater chance to activate more proximal muscles, whereas if we stimulate more distally, there is a greater chance to activate motor pools of distal muscles. But at the same time, we also need to keep in mind the functional characteristics of the stimulation side. Like we know, for example, that L2 neural level can facilitate locomotor or rhythmical activity, whereas a more caudal stimulation side is more known to facilitate an overall tonic extension activation pattern. And then, we also need to keep in mind the individual specific responses. And in order to do that, at least at our side, we basically perform and come up with an individualized map of motor pulse activation as a very first set of assessments right after surgery. And so we do that in supine position, and we test 2 Hertz stimulation, while again applying a narrow field 2 electrode configurations, and then moving both polarity and electrode location both along the central column as well as the lateral columns. And then in order to better interpret the data, we come up with these heat maps. And I just give you an example. If we want to try to come up with an electrode configuration for standing, we really want to facilitate activation of primary anti-gravity extensor muscles without a concurrent great activation of the antagonist flexor muscles. And so just by looking at these 2, vastus lateralis extensor and medial hamstring primary flexor muscles. So I would kind of start with this, at this stimulation side with this 7 minus 8 plus, which gives again high activation of the vastus lateralis and relatively, lower activation of the antagonist muscle. And so I would start from this stimulation side and then expanded following, the dedicated guidelines. But unfortunately, when we move into more functional context, both in terms of motor function, that is in this case standing, as compared to being relaxed in supine position, as well as delivering higher stimulation frequencies, then things become much more complicated. And I just have here an example which seems to me really kind of indicating what I mean. So you see here there are 3 examples where the same 5 electrodes are activated, but we change the polarity. And so when we change the polarity of a single electrode up here, moving it from anode to cathode, we still maintain a very similar activation pattern, leading to independent standing with self-assistance for balance, so very nice motor outcome. But then when we change the polarity of one next electrode over here, changing it from cathode to anode, so just this one minor change then completely changed the activation pattern, leading to the need of assistance at the knees and hips, and also some discomfort, so that the individual here kind of requested to sit down and turn down the stimulation. So this is just an example where sometimes trial and error to date is still needed. And again, we have guidelines that we have also published, but at the same time, this shows the how minor changes in stimulation parameters may or may not end up in very big differences in activation pattern as well as overall motor output. So now, moving into the stimulation frequency, again from the literature, we know that higher stimulation frequencies facilitate rhythmic activity, but at the same time, they also facilitate the activation of interneurons, thus contributing to a greater and greater effect of peripheral sensory information into shaping the evoker responses. And this is just an example showing that when we have the individual standing with 2 different stimulation frequencies here, a lower and a higher frequency, although the activation pattern is overall continuous, but you see that the higher frequency leads to a greater variability of the evoker responses as compared to the lower frequencies. And we interpret this as this is because of greater sensory information included into shaping that response. And again, because of our enabling stimulation strategy, we really want to maximize that. And that's why we really try to get those higher frequencies even into, even when we want to try to obtain overall continuous activation like for standing. And then again, from the literature, we know that lower frequencies like 15 hertz or lower, those are good for inducing an overall extension pattern generation. But when we think about the motor function recovery, they also induce some pulsatile muscle contraction, which is not really good from a functional perspective. And then, when we try to set our stimulation amplitude, we know from neurophysiology studies that lower amplitudes, which is what we are trying to prefer, so they lead to an initial recruitment of lower threshold afferent structures that again are those that we really want to maximize in terms of activation. And then, the more we go into higher amplitudes, there is a greater chance of inducing, efferent volleys, and also possibly directly activating motor neurons and or anterior roads. And this is something that we do not want. And then, to make things even more complicated, so we do not only need a specific set of stimulation parameters per motor task, but we also need an individual specific set of stimulation parameters. And so here I'm just showing you some examples of nice standing motor outcome, which all of them are basically promoted by overall continuous activation patterns, again, that are modulated over time. And this is what we get when we, again, apply individual and task specific parameters. But then, when we tested basically the set of stimulation parameters we have optimized for one individual and then applied it into other individuals, then this is what we got. And you can already, I would say, tell that these are not appropriate activation patterns for standing. And this is, again, like an example of motor behavior. So instead of that nice continuous pattern modulated over time, we often get alternation of EMG bursts with little or negligible activation, and basically resulting in, in a very poor standing pattern. And some of the reasons we believe this happens is, the actual difference, intrinsic difference in spinal cord anatomy. And then, we have a paper under review which really highlights the importance of positioning of the electrode array with respect to the spinal cord. And also there may be some effects of individual specificity of the lesion and following plasticity after SCI. So all these may play a role into, really the need of having individual specific set of stimulation parameters. And so trying to, make a step forward and trying to facilitate the selection of stimulation parameters. Again, we published this paper in the fall of last year. What we tried to do was to go back to our standing database. It's a 10-year database. And then so go back there, get all the data, EMG data, as well as, standing behavior data for 11 individuals, and then use some machine learning to actually classify standing based solely on the EMG data that we have collected. And the other novelty was that we don't only assessed EMG time domain, but we also assessed frequency domain features, which was really rare when we have dealt with epidural stimulation promoted EMG activity. And basically with this machine learning approach, we were able to come up with a very high classification accuracy, so over 95%, in terms of, again, defining a standing event as assisted or independent based solely on the EMG outcomes that we consider. And so based on this high accuracy, we then basically moved again a step forward, and we were able to basically come up with a second algorithm, a prediction algorithm, which can be really helpful in terms of, ranking the effectiveness of EMG activity, as well as, again, facilitating the selection of stimulation parameters. And I'll just tell you an example about how this can be helpful. So, like in this case, we have the same, participant that tested two different sets of stimulation parameters, one to the right, one to the left, one here to the right. And both sets of stimulation parameters resulted in assisted standing. However, you can see here that the score, either the average score for the left leg, right leg, and total score, as well as the score for many of the muscle, is very low, meaning that this activation pattern is very far from independent standing. Whereas with this second step of parameters, you see that, again, the average score is about 0.5. So it's midway between assisted and independent activation pattern. And we also see which muscles are activated as if, in a very good way. So those with shades of blue. So, and this tells us two important practical things. So the first one is that, I would bet by 2 cents that if this individual trains with this set of stimulation parameters for a few days, then he would end up with some sort of independent standing. And the other thing is that here we know, which muscle groups still shows poor activation pattern. And so we could either add a third stimulation program to specifically target plantar flexors in this case, or we may just kind of tweak a little bit one of the two stimulation electro configurations here, basically trying to improve these specific muscle groups. So these are the two ways in which this approach may be helpful. So now, we take a breath and thank the cardinal posed for me the other day, and moved into the the second important context, that is the characteristics of activity-based training and how they can really be important for actually recovering motor function. So here I'm going to present, part of the data. We already published some. We are in the process of submitting for publication, and this is, I would say, 7 years of data collection. And so basically, what I'm going to show is the data for both standing and stepping, collected from two groups of 4, again, chronic motor complete individuals. And here I'm showing you, the main differences in the training paradigms. So I just want to point out that both groups really underwent the same amount of training volume, that is 160 sessions. But there were 3 main differences in the training paradigm. So the first difference is that in the first cohort, there was a first block of stand training with epidural stimulation, followed by a second block of step training. Whereas in the second group, there was a concurrent practice of standing and stepping throughout, the whole training protocol. Then the second difference is that in this second group, once we really realized that the residual descending input was powerful to modulate the motor pattern, we really constantly, challenged and really asked the research participant to contribute to the motor pattern generation. So every single step, every single minute of standing, we really challenged and asked them to really think about the motor output, trying to contribute to it. Whereas this wasn't the case with the first group, simply because we didn't have the knowledge at that time that this approach was actually so powerful. And then the third difference is that, for the first group, the training frequency was always 1 hour a day, 5 days a week. Whereas in this second group, for the second half of the training protocol, they basically trained twice a day, still alternating standing and stepping. But again, at the end of the day, or at the end of the whole training protocol, the training volume was exactly the same. So now I'm going to show you, some results related to standing. And so you see here the first, the cohort number 1. And so all of them showed improvement in standing after the block of stand training. But, the interesting thing is that after the second block of step training, basically 3 out of 4 individuals impaired standing. So stand training improved standing. The subsequent step training impaired standing. When we look at the cohort 2, instead, we see that there is a progressive improvement throughout the 3 time points of the training protocol for all 4 individuals. And also, when we look at when we compare the actual performance in terms of, level of independence and amount of time they were able to stand, basically the cohort number 2 achieved overall better standing performance, both in terms of, again, being able to stand independently with self-assistance for balance with all 4 of them, whereas only 2 of them achieved it up here, as well as in terms of, best performance during training. And, just a quick glance at the activation patterns. So as I mentioned earlier, and I'll go fast here. So you see, usually pre-training, we see this alternation between negligible activity and EMG bursts. And then after stand training, we saw this more continuous pattern modulated over time. But then, especially for the first group, the step training, it almost seemed like it reverted the activation pattern to the pre-stand training status. And the other interesting thing that I mentioned earlier is that by looking at the frequency component, we see that the improvement in standing was also related to an overall decrease in median frequency, as well as its variability, as compared to pre-training and post-step training, where also the standing motor outcome was poorer. So now moving to the stepping ability. So we assessed stepping ability or the data that I'm showing you were assessed at the very end of the training protocol. And what we did, we assessed how many, independent steps were taken, either, the whole step cycle, or just, part of it. And so you see here that if for the cohort 1, basically all 4 individuals needed external assistance throughout the vast majority of the steps taken on the treadmill. And, only showed very few independent part of the step cycle. So either extension or flexion, or very, very little. Whereas, moving into the second group, we can see that all of them showed some level of independence. And again, all of them, some partial, so either flexion right here or extension, with 3 out of 4 showing at least for one leg consistent ability of stepping independently, again on a treadmill, and generating the whole step cycle independently. And then again, these 2 individuals with further training were those 2 that I showed you at the beginning that were able to walk over ground. And this is another key point of including the volitional contribution during training. Basically, this is an example of pre-training without intent to step and with intent to step. Again, this was assisted stepping on a treadmill with body weight support. And you see that it doesn't really change much. It is always assisted, and the DMG pattern doesn't change much. But look at, how things change after training. So over here, after months of training with intent, if you ask them just to think about something else while being stepped on a treadmill, the activation pattern is completely abolished, and so they need manual assistance. But then in the moment that they go back to do what they have done for months, that is volitionally contributing to the step cycle, at that point, the appropriate activation pattern comes up, and they are able, in this case, to step independently for the full, basically, step cycle. So now, how do we interpret this data? As of now, even going through the literature, we don't have direct evidence, but to me, what we have shown really suggests that the spinal circuits engaged during stepping and during standing partially overlap. And so if you train for months only a specific motor task, then this overlapping part is strengthened in a task-specific manner. And this, this can change, as has been shown, in animal studies. Then these neural adaptations can change after several weeks of training a different motor task. But then at this point, you have this common part of the circuitry strengthened for stepping, and this could be, the underlying mechanism as to how 3 of the 4 individuals impaired standing, after the block of step training. Whereas, while interpreting the results of the second group that concurrently practice both standing and stepping, we can hypothesize that there has been an initial progressive reinforcement of a larger neural network over here. And once that got, that neural adaptation got strong enough, they were able to, both perform appropriate activation patterns for standing and stepping. And then by keep practicing both motor tasks, that increased variability actually led to a better learning pattern, throughout the weeks. And again, in considering how important is the volitional contribution, even from that example that I showed you, we also believe that, again, training not only led to relevant intraspinal plasticity, but also supraspinal, either across the lesion or supraspinal. We don't really know where, but for sure, something has happened in terms of strengthening that supraspinal contribution. And now I just want to touch on some unpublished data that, again, we are ready to submit, and this will be really quick, because I think that, we have seen individual specific differences. And so one of the questions that we need to answer in the near future is, are individual specific characteristics important? And so here we have done a study with colleagues at Colorado and California, so Andrew Smith and Kenneth Weber, basically looking at whether, at how the spinal cord imaging through MRI at the lesion site are related to volitional limb movement ability prior to any training. And so what we did, again, we tested volitional lower limb flexion and ankle dorsiflexion with a biodex while applying epidural stimulation. And we assessed the ability either to move or to generate force, and then the EMG amplitude. And as well as 40 MRI outcomes that were all wide matters, both ascending and descending tracts. And basically what we found is that none of the descending tracts we have studied were significantly related to the ability to move the lower limbs. Although on the other hand, some significant and important correlation were found between specific descending tracts that were really within or near the ventral column and the EMG amplitude of key muscles. And you can see here, those are meaningful correlation because we see, for example, again, positive correlations in agonist muscles, as well as negative correlation in antagonist muscles. So I think this data, again, that we're going to submit for publication early, probably can be interpreted as if the lumbosacral spinal circuitry doesn't really require supraspinal inputs from very specific descending tracts to generate a motor output when epidural stimulation is provided, but rather need, rather can interpret many different supraspinal inputs that may differ across individuals. And so with this, I just want to conclude by really thanking all the research participants, all the funding agencies that support our work, Susie Harkema and Claudia Angeli, with whom I really work closely on this epidural stimulation program, all the trainers and staff members, and you all for your attention. And I can take any question now.
Dr. Enrico, this is outstanding presentation, and thank you so much for your time. Any questions from the audience? Any question from the audience? Okay, actually, I have two questions. So can you hear me?
Yes. Mm-hmm.
My first question, you mentioned that you, in your last study, did MRI. Was this appropriate when you have the epidural stimulation on? Like, can you get people with the Medtronic implantation in the magnet?
So that's a very good point. I kind of rushed into this last part, but so all those MRIs were taken right before the implant. And so
Okay.
unfortunately now, so with the newer Medtronic models, they are theoretically approved for 1.5 Tesla, but we haven't really scanned anybody after the implant. So those images were 3T and were taken right after implant. And so one limit of this approach is that we can kind of do this analysis right before any training, but then we can't really follow the spinal basically adaptation and collect MRI after training.
I got you. Perfect. And my second question to you, you mentioned during your presentation you have developed algorithm specifically for the stimulation parameters. Is that the software algorithm, or what type of algorithm you have developed?
Yeah,
to determine electrodes and which parameters?
Yeah, so basically, so it's I'll go back here. So you can find the details here in this paper. And basically, as of now, we don't really have an algorithm that tells you exactly which stimulation parameters to apply. But as of now, again, so what we usually consider is A, the literature, B, the individualized map of motor pool activation that I mentioned here, from which we actually start to expand both the electro configuration and the parameters based off some guidelines we published, like in this paper, in this 2015 paper. But those are really, unfortunately, mostly qualitative guidelines that are important to narrow down the set of parameters to be tried. But it's still a trial and error process. But over here, basically, what I meant was that with this machine learning algorithm, so this is a software that basically now works with a database, that we have put together. But it can work anywhere just by feeding the EMG you collect during your basically standing session, and then almost in real time you can get a feedback of which muscle is activated properly for standing and which muscle is not. And so what I meant by facilitating the selection of parameters is like in this example. So here we know that only the plantar, mainly the plantar flexors are not being activated properly. And so if now I go back to the individualized map of motor pool activation and find out which electrodes directly affect these plantar flexors, I can add, for example, a third program that is specifically targeted on these muscle groups, and hopefully can get a better outcome, rather than just changing things without knowing which muscles are the problem, let's say.
So, Dr. Enrico, I want to thank you so much and for your time and effort, and for your research group for providing an excellent work and helping promoting recovery of persons with spinal cord injury. We have a lot of questions, but unfortunately we came to the conclusion of our time. And thank you so much again, and hopefully look forward to meet with you again in the future.
Same.
Thank you.
Thank you.
Thanks everyone for attending.